Hello, this is the third lecture in a three-part lecture series on cardiology for MRC-PCH, Part 1. The learning objectives within this lecture is to identify the signs and symptoms in cyanotic heart disease and right-to-left shunts. We also want to consider the following conditions as are listed. Question 1. Cardiac failure in the first year of life is commonly seen in which of the following? The answers are as listed, but I want to spend a bit of time talking about rheumatic carditis or rheumatic fever. Rheumatic fever is now an uncommon condition in Western Europe, its occurrence being approximately 1 to 2 per million children per year. Listed on the slide are the Ductus-Jones criteria for its diagnosis. There has to be evidence of either previous infection and or continuing ongoing infection with group A streptococcus. This can be with a raised ASOT titer, or the organism itself can have been directly cultured by means of a throat swab. As you can see, either 2 major or 1 major and 2 minor criteria plus previous evidence of infection or current evidence of infection is required. The systems that count for major include cardiovascular, the joints, neurological in terms of Sydenham's career, dermatological manifestations such as erythema marginatum, or the rarely encountered subcutaneous nodules, so-called Osler's nodes. The minor features are as listed. Question 2. Which of the following congenital cardiac defects presents with cyanosis? The answers are, as you see, are given, and we've dealt on some of these in the previous lectures. I just want to mention 2 conditions. Firstly, with pulmonary atresia, and then secondly, with regard to total anomalous pulmonary venous drainage. In pulmonary atresia, with intact ventricular septum, there is no opportunity for blood to move out of the right ventricle, and therefore there is severe progressive cyanosis from birth. There has to be the establishment of a communication for blood to flow from right to left systems. Hence, shunting may occur across an atrioseptal lesion, i.e. persistence of the patent foramen ovale, with a PDA in order for any blood to be able to go to the lung. This, of course, is a medical emergency. Turning to TAPVD, occasionally known as TAPVC, where the C stands for connection. In total anomalous pulmonary venous drainage, the 4 pulmonary veins, rather than draining into the posterior aspect of the left atrium, drain elsewhere. They may be broadly divided up into 3 types. Supracardiac, where they drain directly into the superior vena cava. Cardiac, where they drain into either the coronary sinus within the right atrium or to another location within that atrium. Or infracardiac, that's to say, below the level of the diaphragm. It's this latter one which is associated with sudden collapse due to obstruction of venous return from the pulmonary bed. This is sudden, therefore can be life-threatening, as no oxygenated blood can return to the left side of the circulation. Classically, the supracardiac, that's to say draining to the SVC, or the ones draining to the coronary sinus within the right atrium or to another site in the right atrium, can be associated with shunting across to the left atrium. This is a right-to-left shunt, and therefore, much as with the infracardiac lesion, of course, will be associated with cyanosis. Question 3. Which of the following statements are true of ostium secundum atrial septal defects? ASDs are relatively common, making up approximately a tenth of all congenital heart disorders. And as you've heard before, there are characteristic features such as the wide fixed splitting of the second heart sound, as the atria left and right function as one. This means there's a relatively fixed amount of blood that goes into the left ventricle compared to the right ventricle. Therefore, there's a consistent ratio of filling of both the ventricles, so the relationship of the left and right ventricle ejection times are fixed. One of the major differences that are seen between secundum ASD and ostium ASD can be seen in the ECG. With secundum ASD, there's right axis deviation and right bundle branch block are characteristically seen, as noted by the RSR in lead V1. In ostium ASD, or otherwise known as partial AVSD, there's left axis deviation or superior QRS axis, best seen in the AVF lead. This is indicated by a negative deflection in lead AVF. Question 4. A 6-month-old girl presents with breathlessness and excessive sweating on feeding. She weighs 4.3 kilograms and on examination has an oxygen saturation of 96% in air, precordial thrill and a pansystolic murmur loudest at the left lower sternal edge. Chest X-ray shows cardiomegaly and plethoric lung fields. What is the most likely diagnosis? The answers are as listed. The point I want to focus on in relation to this question is explaining about the nitrogen washout test, alternatively known as the Hyperoxia test. This is when a child who is suspected of a congenital cyanotic heart disease is placed in 100% oxygen for 10 minutes. If the right radial arterial PaO2 is low, that's to say less than 15 kilopascals or 113 millimeters of mercury, a diagnosis of congenital heart disease can be made. If, however, the PaO2 goes higher than 20 kilopascals, it is not congenital heart disease. Arterial sampling has to be performed as pulse oximetry is not adequate in this setting. It should be noted also that the child must be in a place whereby prostaglandins can be admitted. This is because, as previously noted, oxygen can close ductal material. Hence, if this is a duct-dependent condition, the treatment may actually aggravate the situation. So, use the nitrogen washout test or hyperoxic test with caution. Moving on to question 5. Patent ductus arteriosus. As noted before, this is commonly encountered in the exams, and I think we've dealt with many of these aspects before. Just to note that the majority spontaneously close, but for those relatively few who require closure, this can be done by two means. One is by a lateral thoracotomy scar, the right approach being more commonly used than the left. However, with the advent of transcatheter umbrellas being introduced up into the groin, literally a small umbrella is opened so as to obstruct flow and to affect closure. Question 6. The following manoeuvres may help to overcome spelling, that's to say, cyanotic episodes occurring in Fallot's tetralogy. A list of suggested manoeuvres is given. A spelling or tet episode is when there is spasm of the pulmonary infundibular area. This means there's a failure of blood to go out from the right ventricle into the pulmonary trunk and to the lung. This is associated with a right to left shunt across the ventricular septal defect, and therefore intense cyanosis occurs because desaturated blood is moved directly to the systemic circulation from the right ventricle. There is also no or little blood flow back from the lung of any saturated blood. This is a medical emergency, and the suggested procedures are to place the child with the knees being brought up towards the chest so as to increase the venous return to the right atrium, hence increasing the volume within the right ventricle. Similarly, this increases the systemic vascular resistance, and therefore the back pressure as perceived by the left ventricle is increased. Overall, this is supposed to lead to an increase in right ventricular pressure and therefore may help to overcome the pulmonary infundibular spasm. Other procedures that are carried out include the administration of intravenous propranolol, a beta blocker, to help with relaxation of smooth muscle, i.e. have a direct effect on the pulmonary infundibular spasm, and morphine may alleviate pain, concern, and also may improve the venous return to the heart from the major capacitance vessels. Question 7. No murmur is characteristically heard on auscultation in the following conditions. Transposition of the great arteries in the neonatal period and endomyocardial fibroelastosis are not usually associated with murmurs. All the others are. Question 8. A list of conditions is provided and 3 scenarios are given. Please select the most likely diagnosis from the list above. As before, each option may be used once, more than once, or not at all. Question 1. The correct answer is C. This is quite apparent as the corrected QT interval is greatly prolonged. Prolonged QT interval is associated with sudden death and with hearing disorders. It may be associated with sudden loss of consciousness during exercise, stress or emotion, often presenting in late childhood. In a number of cases, it has been misdiagnosed as epilepsy. Death occurs due to ventricular tachycardia or ventricular fibrillation. There are several phenotypes of its presentation, however, inheritance is often autosomal dominant. Question 2. This ECG shows the delta wave. Delta waves are pathognomic of Wolff-Parkinson-White syndrome. This is where there are aberrant pathways which lead back to the atria and cause runs of supraventricular tachycardia. Question 3. The answer to this is HOCM, that is to say hypertrophic obstructive cardiomyopathy. This can be inherited in a number of different ways and in association with various syndromes. Genetic counselling, therefore, may be helpful, particularly to study whether or not this is an autosomally dominant inherited form, as might be suggested by the question. In summary, then, in this lecture, we've looked at the Duckett-Jones criteria for rheumatic disease, cyanosis, TAPVD, ostium ASD, VSD, PDA, the nitrogen washout test, management for spells occurring in the tetralogy of Fallot, absent murmurs, prolonged QT interval, Wolff-Parkinson-White, and HOCM. Thank you for listening.